Good morning or good afternoon, wherever this webinar finds you. I am Monica Pica with Sachs Healthcare, and I will be your technical producer for today's webinar. Firstly, on behalf of Philips and Sachs Communications, we want to thank all the frontline workers in our audience for your commitment and passion in helping all of us through this very difficult time. We are truly indebted to all of you. Before we get started, I would like to review a few housekeeping details. Today's webinar is being recorded, and an online archive of today's event will be available. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen on a PC or Command R if you are using a Mac. You may ask questions at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. Please direct any technical issues to the Tech Support tab, also located on the right side of your screen. Our speaker will try to answer as many questions at the end of the presentation as time permits. And a copy of the handouts for this presentation is available through a link at the bottom of your screen. Our moderator today is Dr. Dean Hess. Dr. Hess has over 45 years of experience in respiratory care, including clinical, research, teaching, and administrative responsibilities. He is managing editor of Respiratory Care, a lecturer at Northeastern University, and a respiratory therapist at Massachusetts General Hospital. His academic interests include aerosol delivery techniques, adult mechanical ventilation, and critical care monitoring. He is a fellow of the American Association for Respiratory Care and the American College of Critical Care. Welcome, Dr. Hess.
Well, good morning or good afternoon, depending upon where you might be, and thank you, Monica, for that very kind introduction. The title of today's webinar is Safe and Effective Delivery of Aerosolized Medications in the Era of COVID-19. Speaking today on this very timely topic is a friend and colleague, Dr. Arzu Ari. Dr. Ari is a professor and associate dean for research at Texas State University in Round Rock, Texas. Her primary area of research is aerosol medicine, specifically various types of aerosol delivery systems used in the treatment of pulmonary diseases to help improve drug delivery in adults, pediatrics, and infants. Dr. Ari has published 72 peer-reviewed articles, 80 abstracts, 14 book chapters, 2 clinical practice guidelines, and 2 monographs on aerosol drug delivery. She has given more than 260 presentations on these topics at a variety of national and international medical conferences. She serves on the editorial boards of the Journal of Aerosol Medicine and the Canadian Journal of Respiratory Therapy. She is the topic editor and guest editor in Pharmaceutics. Our speaker has disclosed the following financial relationships: Bayer Pharmaceuticals, Arc Medical, Synovian Pharmaceuticals, Aerogen Limited, and Philips. This activity is approved for 1 contact hour for nurses and respiratory therapists. A link to obtain credit will be available at the end of this webinar. And I would like to again recognize the support for this educational activity provided by Philips. At this time, without any further ado, I would like to turn the presentation over to our speaker, Dr. Ari.
Thank you very much, Dr. Hess, for the kind introduction. I also would like to thank everyone in the audience who is here with us today. Last March, my dear cousin passed away due to COVID-19. He was young and healthy, so his passing was quite unexpected. While I was mourning for my cousin, I kept receiving many emails and phone calls from my former students, colleagues, and friends who asked for guidance on how to deliver aerosols to their patients. I didn't know what to say because we had lots of unknowns and no evidence at that time. Then I said, I'm going to think about what is necessary and do what is possible to make a difference in the lives of patients with COVID-19 and to protect clinicians like you. Therefore, in my presentation today, I will teach you how to deliver aerosolized medications safely and effectively in the era of COVID-19. I am one of those professors who believes in the importance of repetition in adult learning. Therefore, if you hear the important, therefore I will repeat important concepts throughout my presentation today. And if you hear the same important information again and again, please bear with me. And remember that this is for your benefit. I would like to accomplish 3 learning objectives today. First, I would like to describe how aerosols and droplets may be the source of respiratory pathogens, and then explain practical strategies on how to deliver aerosolized medications to spontaneously breathing patients with COVID-19 safely and effectively. And then I will discuss infection control and prevention to mitigate your risk associated with aerosolized medications for patients with COVID-19. How am I going to accomplish those goals? First, I will talk about fugitive emissions to tell you what they are, why they are important in this global pandemic, and how they impact viral transmission. And then I will explain types of aerosols to differentiate medical aerosols from bioaerosols. It is an important concept and we need to understand the difference between them. I will review the current literature to provide you some strategies for a safe and effective delivery of aerosolized medications to mild and moderate patients with COVID-19. And then at the end of my presentation, I will talk about infection control and prevention practices that you can use every time when you deliver an aerosol treatment in healthcare and home care settings. So we have a lot to talk about. Let's get started. I'm going to start my presentation with fugitive emissions. And some of you may not be familiar with this term, so I would like to define it before I move forward with this concept. When I say fugitive emissions, I'm talking about aerosols that have been released from the aerosol device during patient expiration. They are medical aerosols that are not inhaled by the patient, but passes into the atmosphere. So fugitive emissions are generated by an aerosol device that you use for an aerosol treatment. They are not inhaled by the patient and released into the environment. So why are we concerned about fugitive emissions? Well, according to previous research, 50% of generated aerosols are fugitive emissions, and that's a lot. Also, the particle size of fugitive emissions ranges from 0.86 micron to 1.43 micron. As you can see, they are small and respirable. If they carry pathogens, that's the problem for all of us. Previous research also reported that the virus can remain viable and infectious in aerosols for hours and on surfaces up to days. Therefore, aerosol and fomite transmission of SARS-CoV-2 is plausible. We need to worry about it. So how do they impact viral transmission? Let me explain it to you through this study that was conducted by Wei and his colleagues, who measured the maximum dispersion distance of smoke particles through the jet nebulizer in normal lung, mild lung injury, and severe lung injury. The maximum dispersion distance of smoke particles in normal lung was 0.45 meter, as opposed to 0.54 meter in mild lung injury. It was greater than 0.80 meter in severe lung injury. And if you look at those pictures on your slide, you'll see that how fugitive emissions can be a problem, especially when you use a jet nebulizer. There are several things that I would like to point out about this study. The first thing that I would like to mention is that they use the jet nebulizer, which is operated with compressed air or oxygen. So external gas flow that you use to operate the device actually increases the dispersion of exhaled particles. And that's a problem in this global pandemic. The researchers of this study measured smoke particles that are less than 1 micron, as opposed to bioaerosols that range from 0.1 micron to 100 microns. So the findings of this study actually represent a small portion of bioaerosols. However, it is still an excellent study to tell us how fugitive emissions can be a problem, especially in this pandemic. Also, this is a laboratory study. They measured medical aerosols, not bioaerosols. And in a laboratory study like this, it is difficult to differentiate medical aerosols from bioaerosols. So I use the term medical aerosols. I said bioaerosols. You probably wonder what I'm talking about. So let me define those terms to you. Bioaerosols are generated by patients during cough, sneeze, sing, laugh, or talk, as opposed to medical aerosols that are generated by inhalers and nebulizers. So if your patient is infected, of course, bioaerosols will carry pathogens. What about medical aerosols? Do they carry pathogens? Well, the answer to that question is yes, if the device is contaminated. And it is easy to contaminate the device because sometimes patients' secretions drop into the nebulizer reservoir and contaminate the device. In other times, healthcare professionals are not careful enough during device preparation and they contaminate the device without even knowing it. Also, device features make a huge influence on the risk of contamination and viral transmission, and that's something we are going to discuss in a few minutes. So if we go back to our previous question, we can say yes, medical aerosols may carry pathogens if the device is contaminated. Let's say the device is not contaminated. So can medical aerosols become contaminated in the lungs before exhalation? That's a question mark. We don't know the answer to that question. I'm going to talk about the risk of transmission and risk of contamination and viral transmission with each device, and I will start with PMDIs. As you all know, PMDIs have less aerosol mass due to low emitted dose. They also have a short treatment time, and that's one of their advantages. Since the drug is enclosed in the PMDI canister, it is hard to contaminate the PMDI during device preparation. Therefore, the risk of viral transmission with the PMDI is low. However, since the PMDIs have become a very popular device in the era of COVID-19, we had shortages in certain states. So some hospitals decided to use the same PMDI in multiple patients because they wanted to keep to make the treatment more cost effective. They also wanted to save the PMDIs and use it in more than one patient. If that's what you're doing in your institution, please stop using the same PMDI in multiple patients. This is a serious global pandemic, and we need to adhere to strict infection control and prevention guidelines. Using the same PMDI in multiple patients is not appropriate in the era of COVID-19. If you use the PMDI in your patients with COVID-19, use it with a wide holding chamber that has a mouthpiece. And I'm suggesting this to you for several reasons. When you use it with a wide holding chamber, you can reduce oropharyngeal deposition. You can minimize the need for hand-breath coordination. You can also ask your patient to exhale inside the wide holding chamber. That way, exhaled bioaerosols that may carry pathogens will stay inside the wide holding chamber instead of going into the atmosphere. So PMDIs are good devices to use in this global pandemic if your patient can use it. What about DPIs? It is very similar to the PMDI because the drug is enclosed in the device and less open to contamination. It also has a very short treatment time, just like PMDIs. And it is hard to contaminate the DPI during device preparation because of its design. However, every time when we use the DPI, we ask our patients to take a deep and fast breathe in from the device because high inspiratory flow rates needed to use the device effectively. When patients try to take a fast and deep breath in from the device, they may start coughing or having an airway irritation. If that's what happens to your patient when you use the DPI, do not use it on your patient, because we don't want them to cough or have airway irritation during aerosol therapy. It will increase viral transmission. So one other thing that I'm going to suggest is that you should not use the DPI in acute respiratory failure, because patients with acute respiratory failure will not be able to generate high inspiratory flow rate needed to use the device effectively. Use the DPI if your patient can have a fast and deep inspiration from the device without having any issue during the treatment. Also, make sure that your patient doesn't exhale inside the DPI, because the DPI is sensitive to humidity. That's why we should instruct our patients not to exhale inside the device, and we should make sure that the device is not kept in high humidity environments such as bathrooms. What about jet nebulizers? This is the most problematic device in my opinion, because it has an open design and more prone to contamination than other devices available on the market. Every time when we use the jet nebulizer, we need to connect it to a flow meter to operate the device with oxygen or compressed air, with compressed oxygen or air. So the flow rate that you use with the jet nebulizer actually increase the dispersion distance of aerosols, and that's the problem, especially in the era of COVID-19. The other problem with this nebulizer is the large residual volume. When I say residual volume, I'm talking about the amount of drug that stays in the nebulizer reservoir after the treatment. It is called that volume because it never goes to the patient. It never aerosolizes after the treatment. So if your job as a clinician is to clean the nebulizer after each treatment, but if you forgot to do that, or if you don't do that, residual volume will stay there and may create a hospitable environment for patients. So if you use this device in a spontaneously bleeding patient, your patient may take the mouthpiece, use the mouthpiece, and breathe through this device. But the secretion may drop into the nebulizer and contaminate the device. The other problem is that if you use this device in ventilator-dependent patients, the nebulizer will be below the ventilator circuit, and the condensate may drop into the nebulizer reservoir and once again contaminate the device. So those are the issues with the jet nebulizer, and it is easy to contaminate the jet nebulizer during device preparation, especially with repeated use. So the risk of viral transmission is high with the jet nebulizer for the reasons that I just told you. However, sometimes we have to use the jet nebulizer for aerosol drug delivery because sometimes we don't have any other choice, and it is the cheapest device that is available on the market. So if you have to use it, I would say pay attention to device preparation and maintenance. That's very important. We don't want to contaminate the device during device preparation. Always use the nebulizer with a mouthpiece and attach a filter to the exhalation port of the nebulizer. And that's something we are going to discuss in a few minutes. Let me explain mesh nebulizers to you. The mesh nebulizers has a mesh that separates the drug from the interface. So the medication has its own isolated space. Excuse me. Since the mesh nebulizer is operated by electrical mains or battery, it doesn't require any external gas flow that may increase the exhaled air dispersion like in jet nebulizer. So that's the main advantage of this nebulizer. Because of its design, it is hard to contaminate the mesh nebulizer, and therefore the risk of contamination with the mesh nebulizer is low. One thing that you need to do when you use the mesh nebulizer is to keep the reservoir cap closed after each use. So what about the risk of SARS transmission with aerosol generating procedures such as tracheal intubation, suction before intubation, non-invasive ventilation, and nebulizer treatment? According to the findings of this study, the risk of SARS transmission to healthcare professionals with the tracheal intubation was 6.6-fold, as opposed to 3.5-fold with suction before intubation, and 3.1 with non-invasive ventilation. Look at the number that they obtained with the nebulizer treatment. It was 0.9. It was much, much less than other aerosol generating procedures that we use in our clinical practice. So maybe it is not as bad as we think, although nebulizer treatment is an aerosol generating procedure. So how should we deliver aerosols to mild patients with COVID-19? How can we make it safer and more effective? Of course, device selection is very important. If your patient is awake and is able to perform the optimum delivery technique required by the inhaler, use the inhaler. You can use the PMDI and attach a wire holding chamber to the PMDI. If your patient can generate the high inspiratory flow rate, use the DPI. But do you think every patient can generate a high inspiratory flow rate with the DPI? Well, that may not be the case, especially with elderly or in patients with physical and cognitive ability impairments. According to the findings of this research, peak inspiratory flow rate decreases with age and proportions of non-effective inhalations increase with age. So if you're dealing with an elderly, inhalers may not be the right choice, and maybe DPIs may not be the right choice because they won't be able to generate the high inspiratory flow rate needed to use the device effectively. So therefore, it is very important to choose the right device for the right patient. So here are some things that you need to remember. Every time when you use the DPI, make sure that your patient can generate high inspiratory flow rate by taking a fast and deep inspiration from the device. And if they start coughing or having an airway irritation, you should not use the DPI. You should not use the DPI in acute respiratory failure either, because those patients will not be able to use the DPI effectively. You should not use the same PMDI in multiple patients because we need to adhere to strict infection control and prevention guidelines, especially in the era of COVID-19. You can use the PMDIs with a wire holding chamber. And you may ask me what type of wire holding chamber you should use. There are different types, and one type is called conventional wire holding chamber, and the others are anti-static wire holding chambers. I recommend for you to prefer using an anti-static wire holding chamber over a standard wire holding chamber because static charge on the conventional plastic wire holding chamber reduces drug delivery, and that will impact your treatment, and patients will not be able to benefit from their treatments. So choose an anti-static wire holding chamber if you can. If you don't have that, you can wash the conventional wire holding chamber with soap and water and let it air dry, and that will remove some of the static charge from the wire holding chamber. The other thing is that you may ask me if there is any difference between different brands of anti-static wire holding chamber. Previous research showed that these two wire holding chambers that you see on your slide are equivalent for the delivery of albuterol and beclomethasone. What about inhalation delay? That makes a difference. If your patient delays his inhalation by 10 seconds, the emitted dose will be reduced by 20%. And it will happen with any type of wire holding chamber that you use during treatment. So make sure that your patient starts his inhalation as soon as you actuate the PMDI. What about breath hold? Every time when we use an inhaler, we ask our patients to hold their breaths for 10 seconds. It doesn't matter if we use a PMDI or a DPI, we always ask them to hold their breaths for 10 seconds. But sometimes they cannot hold it for 10 seconds because they are critically ill or they don't have the physical ability to do it. So in this case, we ask them to hold their breath as long as they can. Please remember, lung dose can be increased by 11 to 26% with 5-second breath hold. And that's why it is very important to hold breath. So as you can see, when you use an inhaler, you need to accomplish several important steps to achieve an effective aerosol treatment. However, some patients may not be able to do it because of their physical or cognitive impairments. In this case, we have to use a nebulizer. In other situations, drug formulation may not be available as an inhaler, and once again, we have to use a nebulizer. So in this case, prefer using a mesh nebulizer over a jet nebulizer because they are 2 to 3-fold more efficient than jet nebulizers, and they are safer than jet nebulizers for the reasons that I told you earlier. Every time when you use a nebulizer, use it with a mouthpiece and attach a filter to the exhalation port of the nebulizer. Now you're wondering why you need to put a filter to the exhalation port. Let me explain it to you. Attaching a filter to the nebulizer is 93% effective in capturing exhaled aerosol droplets. It's a very basic procedure, but it is very effective. So if you're using a jet nebulizer, all you need to do is to attach a bacteria filter to the 6-inch large bore tubing like you see in the slide. If you use a mesh nebulizer, you can attach the filter to the mouthpiece. However, there is something you need to be careful about this one. There is an exhalation valve located in the mouthpiece. So you should not block the exhalation valve with the placement of the filter. How you're going to avoid this situation? It's easy. If you have a 22 millimeter silicone adapter in your unit, use it between the filter and the mouthpiece, and that will solve the problem. I didn't have that adapter in my research lab. That's why I couldn't use it when I took those pictures for you. But if you have it, use it with the mesh nebulizer. Also, I recommend for you to use a HEPA filter with nebulizers if you can, because they will be much more efficient than regular bacteria filters. I said use a mouthpiece instead of a face mask. Let me explain you why. In this particular study, the researchers quantified exhaled aerosols released to the environment with jet and vibrating mesh nebulizers using face mask, unfiltered mouthpiece, and filtered mouthpiece. So if you see the table, the quantity of exhaled aerosols with the face mask was the largest. It went down when they used unfiltered mouthpiece, but it was lowest with the filtered mouthpiece. And when they used the vibrating mesh nebulizer, it was close to 0. So that's why we need to use the mouthpiece, because using a mouthpiece will decrease the quantity of exhaled aerosols released to the environment, and that will be safer for you. When you use a mouthpiece, you can increase the delivery efficiency of the device, and that's something we found in our previous research, in which we reported that drug delivery was greatest with the mouthpiece, while the aerosol mask was the least efficient interface. So use the mouthpiece instead of a face mask. And that makes sense because face mask has 2 large holes on the sides, and you lose a lot of aerosols escaping into the atmosphere. And that's something we do not want to do in the era of COVID-19. So I gave you several strategies, but I would like to repeat them one more time so that you can use them in your clinical practice. First, avoid all unnecessary aerosol drug delivery. If your patient doesn't need an aerosol treatment, do not use it. If you have to give an aerosolized medication to your patient, use an inhaler instead of a nebulizer. And I suggest using a mesh nebulizer over a jet nebulizer. Every time when you use a nebulizer, use it with a mouthpiece and attach a filter to the exhalation port of the nebulizer. When you deliver aerosolized medications, do it in negative pressure rooms. Administer aerosol therapy in negative pressure rooms and wear personal protective equipment. I value each and every one of you, and I don't want anything happens to you. So please take care of yourself. What about moderate patients with COVID-19? They usually have acute respiratory failure, and in the past, every time a patient had an acute respiratory failure, we used the high flow nasal cannula for the treatment of that patient population. And then we thought maybe we should use the high flow nasal cannula in this patient population, but that created a hot debate in the era of COVID-19, because some clinicians and researchers thought that we should use the high flow nasal cannula for aerosol drug delivery to moderate patients with COVID-19, because they thought it is effective in the treatment of hypoxemic respiratory failure. They thought early intubation is a high-risk procedure and we should avoid it as much as we can. They are worried about prolonged ICU stay because of a limited number of ventilators available in the ICU. So they said, let's use the high flow nasal cannula. However, another group was completely against this idea, and they said, no, we should not use the high flow nasal cannula for the treatment of moderate patients with COVID-19, because dispersion of bioaerosols to the environment is high with the high flow nasal cannula. And increased dispersion may lead to viral transmission. So let's talk about dispersion of exhaled aerosols. In this study, in this slide, I am presenting you two separate studies that was published by two different groups of researchers. This study that I present on your left was conducted by Ray and his colleagues, who used the high flow nasal cannula at 60 liters per minute and 10 liters per minute. The table that you see on your right was published by Ive and his colleagues, who used simple mask, non-rebreather mask, and Venturi mask at various flow rates using different lung models. Both of those studies measured the maximum dispersion distance of exhaled aerosols. They use the same methodology, similar breathing parameters. So when the high flow nasal cannula was used at 60 liters per minute, the maximum dispersion distance was 17.2 centimeters. And it was very close to the simple mask at 15 liters per minute. Look at the table on your right that has a bracket. The number is 11.2 centimeters with the simple mask at 15 minutes, as opposed to 17.2 centimeters with the high flow nasal cannula at 60 liters per minute. When the researchers used the non-rebreather mask or Venturi mask, the maximum dispersion distance ranged from 23.5 centimeters to 39.7 centimeters, and this is much higher than the high flow nasal cannula at 60 liters per minute. When the flow rate was reduced from 60 liters per minute to 10 liters per minute, the maximum dispersion distance reduced from 17.2 centimeters to 6.5 centimeters. So you may say, okay, maybe exhaled air dispersion is not an issue, may not be an issue. What about bacterial growth? And this is a clinical study that was conducted on 19 patients using the high flow nasal cannula at 60 liters per minute and oxygen mask at 8.6 liters per minute. And they measured bacterial growth through patients' room air and settle plates that were placed at 0.4 meter and 1.6 meter from the patient. And the findings of this study showed no significant difference in bacterial growth in the air sample and settling plates between the high flow nasal cannula and the oxygen mask at 1, 2, and 5 days of incubation. So I am one of those clinicians who think we should use the high flow nasal cannula in moderate patients with COVID-19. So here are some suggestions for you. First, you need to use a mesh nebulizer and place it prior to the humidifier. Keep the reservoir cap closed after use, and that way the medication can stay in its isolated space. Make sure the prongs are well fitted and not loose, and place a mask on patient's face during the high flow nasal cannula therapy. So you may wonder why you should put a face mask on top of the high flow nasal cannula. Let me explain it to you through this study. which looked at the impact of mask on exhaled air dispersion using no mask, surgical mask, and N95 mask. All the green areas that you see on those pictures are exhaled aerosols. And they simulated normal cough, mild cough, and poor cough in this study. Regardless of the type of condition that they tested in this particular research, N95 mask was more effective than a surgical mask in preventing expelled air leakage during coughing. So use a face mask on top of high flow nasal cannula. But it is important to choose the right type of mask. So if you decide to use an N95, make sure that your N95 respirator doesn't have an exhalation valve. Some of them has an exhalation valve, and if you use that one in your patient, the exhalation valve will open every time when your patient exhales, and you will be exposed to infected bioaerosols, and that's something we do not want to do in the era of COVID-19. So if you have N95 respirators without an exhalation valve, use it. But I also know that N95 respirators are limited, and we use them in healthcare providers. So in this case, just use a surgical mask with the high flow nasal cannula. That will be good. If you decide to deliver aerosolized medications through the high flow nasal cannula, I recommend for you to use a mesh nebulizer for aerosol drug delivery because they are 2 to 3-fold more efficient than jet nebulizers. They also don't add additional flow to the system. That's why it will be more effective. Because when you use the jet nebulizer, it adds additional flow to the system, and that's something we don't want to do. You need to adjust the flow rates. So when you use a nebulizer with the high flow nasal cannula, make sure that you use a septic technique during device preparation to prevent device contamination and viral transmission. Place the mesh nebulizer prior to the humidifier. Previous research showed that when you place the mesh nebulizer prior to the humidifier, you increase the delivery efficiency of the device compared to its placement near the patient. When you place the mesh nebulizer prior to the humidifier, you can leave it there in the next 28 days, and all you need to do is to put the medication inside the nebulizer reservoir. And always clean the nebulizer based on the manufacturer's guidelines to prevent device contamination and viral transmission. What about gas flow? This is a study that we conducted with our colleagues in Brazil, in which we wanted to quantify aerosol drug delivery with the high flow nasal cannula at 10, 30, and 50 liters per minute. Lung dose at 10 liters per minute was 17.2%, as opposed to 5.7% at 30 liters per minute. When we increased the flow rate to 50 liters per minute, lung dose dropped to 3.4%, and that was a lot. So here's what I'm suggesting to you. Since gas flow has an inverse relationship with lung dose, our goal is to improve the delivery efficiency of the device during the treatment. Let's say your patient is going to use the high flow nasal cannula at 50 liters per minute. If you need to deliver an aerosol treatment to your patient, decrease the gas flow rate during aerosol therapy to improve the delivery efficiency of the nebulizer. That way, your patients can benefit from your treatment. However, you need to use this technique only if your patient is able to tolerate low flow rates. It shouldn't be a problem. Honestly, if you use a mesh nebulizer, it will take 4 to 5 minutes to complete the treatment. And your patient should be able to tolerate low flow rates at that time. And then after your treatment, you can go back to your original settings and set it at 50 liters per minute, for instance. But once again, safety is important, and you need to monitor your patients and titrate gas flow and FiO2 based on your patient's response to ensure low flow rates are tolerated by your patient. And delivery technique is another important thing that you need to pay attention. Sometimes when the high flow nasal cannula is used by our patients, we just keep it in the nares and place a face mask on top of high flow nasal cannula to deliver aerosols with the PMDI or the jet nebulizer that you see on your slide. And if that's what you're doing in your clinical practice, please remember that keeping the high flow nasal cannula in the nares will decrease aerosol direct delivery, and that's something you don't want to do. In other times, clinicians remove the high flow nasal cannula and use the PMDI or the jet nebulizer in the traditional delivery, using the traditional delivery technique, and that's not effective either. So I suggest delivering aerosols through the high flow nasal cannula by placing the mesh nebulizer prior to the humidifier. So do not discontinue the high flow nasal cannula. Do not place a mask on top of the high flow nasal cannula. And every time when you use the high flow nasal cannula on your patient, place the surgical mask on your patient's face during therapy. So here are some strategies for you. Again, use the high flow nasal cannula for aerosol delivery before severe hypoxemic respiratory failure. Before they develop severe hypoxemic respiratory failure. Use the mesh nebulizer, place it prior to the humidifier, and keep the reservoir cap closed. Consider reducing the flow rate during therapy if your patient tolerates the low flow rate. Make sure prongs are well fitted and not loose. Place surgical mask on the patient's face before therapy, and always wear personal protective equipment and administer aerosol therapy in negative pressure rooms. Let's talk about infection control and prevention. I think it is time to assume all patients may be infected and apply good personal protection and good aerosol administration practices. How are you going to do that? You need to isolate patients in negative pressure rooms. You need to bundle activities to minimize the number of times entering the room. You need to train your staff on infection control and prevention in the era of COVID-19 so everyone will be on the same page. Use personal protective equipment, Use personal protective equipment for aerosol and droplet protections and adhere airborne precautions. Always wash hands before and after each treatment. When you are ready to deliver an aerosol treatment, wear clean gloves before filling the nebulizer reservoir and administering aerosol therapy. Once again, you need to use proper aseptic technique to avoid contamination and of aerosol devices and medications. Your patients should wear simple masks when possible and between treatments, and always have tissues available so that they can use it when they cough or sneeze. Your job is to reduce the release of bioaerosols or dispersion of bioaerosols into the environment. And you can do it by using the mouthpiece or filter with the nebulizers, or you can use a breath-actuated nebulizers, or you can put a face mask on top of your high flow nasal cannula. So there are so many strategies that you can use to do that. What about home care? You can train your patient. You need to train your patients and family members on infection control and prevention. That way, your patient will know what to do. And there are excellent guidelines prepared by the World Health Organization and CDC. You can refer them to those guidelines. Comply with home isolations, and your patients should comply with home isolations and stay isolated in a well-ventilated room with open windows. Families should assign a family member with good health to take care of the patient. So if you're coming from a family like mine, who has very strong family boundaries, they all would like to be involved in the care of the sick person. But that's not the right thing to do in the era of COVID-19. A family member with good health should be enough. Only one person should be enough. Patients should avoid shared spaces and personal household items. If they have to use the shared spaces, they should stay at least 1 meter away from family members and wear a face mask. They should wash hands and use proper aseptic technique to avoid contamination of aerosol devices and medication. And wear clean gloves before filling the nebulizer reservoir and administering aerosol therapy. They should administer aerosol therapy in a location outside on a patio, porch, or in a garage. That way, exhaled bioaerosols will not distribute in the house, and it will be safer for the rest of the family members. They should use tissues and discard them in a trash can placed in the patient's room. And always, they should always know how to clean their reusable nebulizers with soap and water. They should rinse them. They should disinfect them between treatments. And mesh nebulizers should be cleaned based on the manufacturer's guidelines. The content of my presentation today is based on my previous publications in The Lancet, Respiratory Medicine and Expert Opinion on Drug Delivery. So if you would like to learn more about this subject, please feel free to download those articles. They are free of charge. I will be happy to share them with you if you would like to contact me via Twitter or my email. And I'd like to conclude my presentation with one of my favorite quotes from Marie Curie, who said, "Nothing in life is to be feared. It is only to be understood. Now it is time to understand more so that we may fear less." There are lots of unknowns in this global pandemic, and we are fearful of many things. But please remember, we are strong when we know our fears and limitations. And it is time to think about what is necessary and do what is possible. You're doing such an excellent job in the lives of patients with COVID-19, and therefore you are the heroes of this global pandemic, and I'm very proud of being one of your colleagues. And this actually concludes my presentation. Thank you very much for listening to my talk. Before we begin the question and answers period, I will turn presentation back to Dr. Hess, who will tell everyone how they can obtain their continuing education credits for this session. Thank you.
Thank you very much, Arzu, for that most timely and thought-provoking presentation. I would like to remind the audience about how they can obtain their continuing education credits. This educational activity is approved for 1 contact hour. To obtain your continuing education credits, go to saxtesting.com/BL. You will need to register at this site, complete the evaluation, and upon completion, you will be able to print your certificate of completion. Before we begin the question and answer period, I would like to again thank Philips for their support of this educational activity. I would also like to point out that an archive on-demand version will be available on betteroutcomes.org. An email will be sent to all registrants when it is available. The on-demand version will be accredited for nurses and respiratory therapists. So with that, let's begin our Q&A session. Arzu, there are a lot of questions that have come in during your presentation. We'll try to address as many of these as we can over the next 10 minutes. So there were a couple of questions about patients with tracheostomy. So what about fugitive aerosols in patients with a tracheostomy? And if you are providing, or if a patient is being provided a cool aerosol, such as to a trach collar, will that generate fugitive aerosols, and how might that be addressed?
That is an excellent question, and I get lots of emails about that particular subject. So we wrote a commentary on this area of research, and hopefully it will be published in a journal article soon. But something that I would like to say that, yes, fugitive emissions will be a problem for patients with tracheostomy. And we do not want to use the tracheostomy collar to deliver aerosolized medications, because that will expose you to infected bioaerosols. It will also increase the dispersion of exhaled bioaerosols into the atmosphere, and that's an issue in the era of COVID-19. So what you need to do is to use the TPs instead of the tracheostomy collar or the tracheostomy mask for aerosol drug delivery or regular cold humidification or oxygen. Hello? Do you hear me?
Yes. Yes,
oh,
continue.
Okay. So I was suggesting to use the TPs instead of the tracheostomy mask because it will provide clinicians a closed system. We do not want to break the circuit by placing the nebulizer into the system. So that's why I recommend using the mesh nebulizer, putting it in the circuit and leave it there in the next 28 days and place a filter to the exhalation port of the TPs. And that way you would reduce exhaled aerosols or fugitive emissions during aerosol therapy or during oxygen therapy when you use the humidification system, high flow humidification system in patients with tracheostomy. So PMDIs and jet.
I'm sorry. Continue.
So PMDIs and jet nebulizers may not be appropriate because you need to break the circuit every time when you would like to place the device into the circuit. So mesh nebulizers may be a better option for that patient population.
Okay, I'm sorry I kept interrupting you when you had additional thoughts that you wanted to share. So my apologies for that. But I think the question relates to not so much the delivery of aerosolized medications to a patient with a tracheostomy, but just the continuous delivery of an aerosolized cool mist. So would it be, do you think it would be better to use a heated humidification rather than a cool aerosol? Any thoughts about that?
Yes, it would be. I also suggest using the TPs instead of an aerosol mask because tracheostomy mask, because the tracheostomy mask has a hole in it which will expose clinicians to exhaled bioaerosols. That's why we would like to minimize our exposure to exhaled aerosols by using the TPs or by placing a filter to the exhalation port of the TPs.
Yes, I agree with the TPs. I think if you're going to use a filter, you need to be cognizant of the filter that you're using to assure that it will not increase its resistance if exposed to humidity or aerosol over time.
Yes, I agree.
There are a few practical questions. How many times can this is actually Jessica asking, how many times can the antimicrobial filter be used with an individual patient? In other words, do you need to discard it with each use, or can you use it for several treatments throughout the day? What do you think about that?
Well, I cannot tell any certain times or any certain treatments with each type of, for the placement of each filter. But one thing that I would like to say is that we need to monitor the patient to make sure that it doesn't increase work of breathing of the patient. So as long as the patient is comfortable and doesn't have any sign of an increased work of breathing, we can keep the filters, we can keep the same filters, but if it is contaminated, if you see secretions, if you see fluid in it, if you see it has some condensation in it, that will be the time to change the filter.
Okay, there are a couple of questions. Eric and Cheryl both have questions about breath-actuated nebulizers and whether they could be used. I think that what they're getting at here is one can place a filter on the nebulizer as you described, but if the patient takes the nebulizer out of their mouth and the nebulizer is spilling aerosol into the room, that might still be a problem. So how do you feel, what are your thoughts about breath-actuated nebulizers?
That is an excellent question. I tried to point out in my presentation that breath-actuated nebulizers can be an option to minimize the dispersion of exhaled aerosols, because breath-actuated nebulizers actually generate aerosols only in inspiration. So since there is no aerosol generation during expiration, it is safer. Since there were no studies conducted on that particular subject, I couldn't share it with in my presentation today, but I believe that we can use the breath-actuated nebulizers in the era of COVID-19.
So a couple of related questions. Debbie wants to know about the circular nebulizer. Would that be an option?
That's a good one. The circular nebulizer has a reservoir back attached to the nebulizer. So when you exhale, exhaled bioaerosols goes to the reservoir back, and patients inhales the medications from the reservoir back every time when you deliver the treatment. But there is also an exhalation valve attached to the nebulizer. If they place a filter to that particular space, I think they can use the circular nebulizer. Otherwise, they need to, they need to be careful about aerosols coming out of the exhalation valve.
Okay, thank you for that. I'm looking over the questions here. Jill asks a very, I think, important practical question, and that is, if a negative pressure room is not available, then what should we do? Because negative pressure rooms, there may not be enough in a hospital for every patient receiving aerosol therapy.
Yes, that is an excellent question, and that is an issue in these days, because we have so many patients who may need aerosol, who may need an aerosol treatment. So they can use the same room for the multiple patients with COVID-19 when they are ready to deliver aerosolized medications. I also know that some hospitals use tents or canopies to minimize the dispersion of exhaled aerosols. That will be an option. They also need to use the other strategies that I gave to them in my presentation today to minimize the dispersion of exhaled aerosols.
Okay, I think that, we'll have, maybe I will take the moderator's prerogative and ask the last question or make the last comment. And this has to do with patient selection. So it seems to me that the best way to protect ourselves from fugitive aerosols is to limit aerosol therapy only to the patients who need it. And I would state that you can agree with me or disagree with me, Arzu, but
I never did.
Bronchodilators are really not indicated just for COVID-19 pneumonia or infection. So just because a patient has COVID-19, I don't think is an indication for the delivery of an aerosolized bronchodilator. I don't know if you want to comment on that.
That is exactly right, and I would like to say that I would never ever disagree with you. You are a legend of aerosol therapy. Of course, I will agree with you, Dr. Hess, and thank you very much for your comments. As I mentioned to the audience earlier, we should avoid all unnecessary aerosol treatment in the era of COVID-19. If patient doesn't need it, we should not use it.
Okay, well, thank you again, Arzu. They are about ready to turn the lights out on us, so let me turn this back over to Monica to wrap up today's session.
Thank you. And this does conclude our webinar for today. I'd like to remind the audience that there is a survey for you at the conclusion that will pop up immediately. And we would greatly appreciate you sharing your opinions on today's webinar. We do value your feedback. Thank you again on behalf of our presenters, Saks Healthcare Communications, and our sponsor, Philips. I hope you enjoy the rest of the day.